Right?
Yep.
Okay. Okay, welcome to Journal Club. This is Hannah Crow. I'm going to be going over a landmark trial today that's an endocrine topic, but also relevant for you cardiology nerds. The journal article is entitled Cardiovascular Risk Reduction with icosapent ethyl for hypertriglyceridemia intervention trial. So we will be discussing cardiovascular risk, triglycerides, and icosapent ethyl, which the trade name for that drug is Vascepa, and it's an omega-3 fatty acid. So this was published in the New England Journal of Medicine in January 2019. And like I said, I'm going to go over triglycerides, omega-3 fatty acids. I think we're sort of familiar with what those are, but I'm just going to do a little review over those. I'll talk about the trial and then some discussion points. So it's been shown that adverse cardiac risk still remains high in patients for secondary prevention, even if they're already on a statin. They still have residual risk for adverse cardiac events like a second MI, stroke. And residual cardiovascular risk is made up by a lot of different factors. Hypertriglyceridemia or hyperlipidemia is one of them. Also obesity, smoking, diabetes, hypertension, and inflammation. So the focus of this talk will be addressing the component of hyperlipidemia and hypertriglyceridemia. The Framingham Heart Study showed us that patients with low HDL and high triglycerides have a 4 times higher risk of coronary artery disease. And hypertriglyceridemia is an independent marker of increased cardiovascular risk. There have been some studies that have shown that statins combined with fibrates and niacin have shown no ASCVD benefit. Those were 2 drugs that we thought could help lower hypertriglyceridemia, but really only the omega-3 fatty acid, particularly EPA, has been shown benefit, and that's what we're going to talk about today. So REDUCE-IT got its inspiration from the JELIS trial. JELIS stands for Japan EPA Lipid Intervention Study, and they looked at a Japanese population where they added EPA to patients who were already on a low or moderate intensity statin, and they looked at adverse cardiac events. They did show that EPA did have a benefit, but it was not statistically significant. This wasn't a placebo-controlled trial, and like I said, it was limited to a Japanese population. So that study got some buzz in 2007, and based on that study, they decided to do a placebo-controlled trial with EPA, and that's how we got REDUCE-IT. So EPA, or eicosapentaenoic acid, is an omega-3 fatty acid. It's the drug in question for REDUCE-IT. Omega-3 fatty acids fall under the category of unsaturated fatty acids. They are also essential, meaning our bodies need them. We need them, we cannot make them, and they're precursors to a lot of anti-inflammatory markers and prostaglandins. If you look at fats, you can separate them into saturated, monounsaturated, and polyunsaturated. Your saturateds are going to be things that are solid at room temperature, like butter, animal fat. Monounsaturated are vegetable oil, olive oil, those sort of things, and the polyunsaturated fatty acids are omega-3 and omega-6 fatty acids, and we get those from fish, particularly salmon. So EPA is an omega-3. And I just want to touch on how you get the name omega-3 really quick, because I think we hear that term and don't really understand what it means. But the omega carbon refers to the carbon that has the first double bond. So omega-3 means the first double bond is 3 carbons in. So EPA, or eicosapentaenoic acid, is an omega-3. As you can see here, that first double bond is 3 carbons in. Icosa means it has 20 carbons. Penta, it has 5 double bonds, and noic acid, it's a fatty acid. So That's what they studied. To make it in a lab, they have to add an ethyl ester on it so they can mass produce it, but all it really matters is where that double bond is. There's been some question, well, can we just buy this stuff over the counter? No, you can't. This is EPA that has been highly purified, and the stuff that you get over the counter has DHA in it as well, and it is not as concentrated as Vasipa.
I just want to say, I don't break into these very often, but the look on Dr. Crow's face of utter enjoyment of talking about this is quite amazing. And
yeah.
Cardiology nerds have nothing on her at this point.
Yeah, we're also in Dr. McElwain's closet in the clinic, so this is really fun.
And the pharmacist in me is loving the whole like med chem explanation there.
Okay, so let's get into the trial. So the clinical question for REDUCE-IT essentially was, in patients with coronary artery disease or diabetes, plus an additional risk factor with elevated triglycerides, does adding Vasipa reduce cardiovascular risk when added to a statin? The primary outcome for this study was a composite of cardiovascular death, non-fatal MI, non-fatal stroke, coronary revascularization, and unstable angina. The study itself was a multi-center, randomized, double-blind, placebo-controlled phase 3B study. About 8,000 patients participated in the study, 4,000 in each arm. The mean follow-up for this study was about 5 years. I just want to point out that Fourier and Odyssey, those trials looking at the PCSK9 inhibitors only went on for about 2 years, so the study was about double the length of those. And this was an intention to treat analysis. Randomization of the patients was stratified by primary prevention, which made up a smaller portion of the patients, secondary prevention, geographic location, and if they were already on ezetimibe. Ezetimibe inhibits cholesterol uptake in the small intestine, and the reason why that is important is because ezetimibe or Zetia is shown to reduce ASCVD risk, and that was the Improve It trial. So if they were on ezetimibe, they tried to put equal amounts of those patients in each bucket. So moving into inclusion criteria, patients had to have a fasting triglyceride level between 150 and 500. They had to have an LDL between 41 and 100, and they had to be on a stable dose of statin for at least 4 weeks. Additional inclusion criteria, you had to have coronary artery disease. You had to be at least age 45 if you had coronary artery disease, and they defined coronary artery disease as having documented multivessel coronary artery disease, a prior MI, carotid artery disease, or prior stroke, or if you had documented peripheral arterial disease. Sorry. You could also be enrolled in this study if you were diabetic. If you were diabetic, you had to be at least age 50, and you had to have one additional risk factor. And I have listed here all of the potential risk factors you could have. If you're a female who is 65 and diabetic, you could get in. Or if you were an active smoker, you had hypertension, a low ABI, or if you had any signs of microvascular disease, including retinopathy. You were excluded from the study if you had heart failure, severe liver disease, a hemoglobin A1C greater than 10, if you had planned coronary intervention or surgery. If you were on a fibrate or a niacin, you were excluded. HIV/AIDS patients were excluded, and patients with very high triglycerides or familial hyperlipidemias were excluded from this study. Some other notable features for the patients, about 6% were on ezetimibe, 94% were on a moderate or high intensity statin. There were about 6% of patients who were on a low intensity statin or no statin at all. I think those no statin people were eventually excluded from the analysis. The mean age of the patients were 64. Only 28% were female. And the median cholesterol levels at baseline of the study for triglycerides, the level was 216. For LDL-C, the median was 75, and for HDL-C, it was 40. So I have a graph here of the composite primary endpoint of cardiovascular death, MI, stroke, coronary revascularization, and unstable angina. The placebo is in the red and Vascepa is in blue. The placebo was a mineral oil tablet, which I'll touch on here in a little bit. But as you can see, Vascepa at 5 years had a 23% event rate compared to placebo, which was 28%. That gives us a relative risk reduction of 25%, an absolute risk reduction of 4.8%, and that gives us a number needed to treat of 21. So this is excellent data. I just want to touch again on the PCSK9 4-year and Odyssey trials. The relative risk reduction for those PCSK9 inhibitors was about 15%, and for Vascepa, it was 24.8%. So this drug is effective. The secondary endpoint was a composite of sorry, I can't talk today. It was a composite of cardiovascular death, MI, and stroke. For the secondary endpoint, we have a relative risk reduction of 26.5% and an absolute risk reduction of 23.6%. That also gives us a number needed to treat of 28. So this was also effective in the secondary endpoint as well of any cardiovascular death or stroke. The bottom line here is that Vascepa 2 grams twice a day reduces cardiovascular death, non-fatal MI, stroke, coronary revascularization, and unstable angina. And that's specifically in patients who are at risk compared to placebo. Some of the criticisms I have about this trial aren't many, but women only contributed about 28% of the patient population. Women, we think maybe are at a little bit higher risk, especially in this postmenopausal age. So I would have liked to see more women enrolled in this trial. The placebo was a mineral oil pill, and there is some question on was it a true placebo or not. I don't know specifically what the mineral oil pill was made of, but could those patients have gotten some form of fatty acid? Maybe. And then only about 6.5 of the patients in each arm were on a low intensity statin. They weren't maximized on a high or moderate intensity statin, which does not go along with what guidelines recommend for diabetic patients. They recommend patients should be on at least a moderate intensity statin, and patients for secondary prevention and for coronary artery disease should at least be on a moderate or high intensity statin. So patients with low intensity statins were included. So in conclusion, Vascepa is indicated for high-risk patients with elevated triglycerides. Statins are still going to be your first line for patients with elevated triglycerides. Like I said, over-the-counter fish oil supplements are not going to be a substitute for this drug. But I think this is a nice drug to reach for if you do have a patient in clinic who has these risk factors and has elevated triglycerides, because we don't have to worry as much about drug-drug interactions. Thanks for tuning in. I'm going to hand it off to Dr. Cronister.
Yeah, so I feel like in half of these journal clubs, my initial response is it's interesting, because there's so much that we do that is not based off of perfect evidence. And so the thing with omega-3 fatty acids is that we've been looking into those things since the dawn of mankind, which was probably 1996. And we've had so many studies that have looked at, every permutation of do fatty acids help cardiovascular disease? Because we know that kind of, dietary omega-3 fatty acids have been shown in these blue zones across the world where people live to 150, that's a primary parameter of why they have reduced cardiac mortality. is because of these fish-derived or diet-derived omega-3 fatty acids. And so we see that fish oils in vitro reduce inflammation. They increase anti-inflammatory mediators. They reduce C-reactive protein levels. But we've not seen pharmacologically derived versions of EPA and DHA showing the same benefit. And so researchers for the last 20, 30 years have looked at every single possible way to see if there's benefit. They've tried EHA by itself. They've tried DHA by itself. They've tried levels of like a gram. They've tried levels of 2 grams. Now they're doing 4 grams in this study. They tried it for primary prevention. They tried it for secondary prevention. So this specific study looked at a very high dose, so 4 grams. And as Dr. Crow said, it was based off of the JELIS study, which was kind of the same study. So secondary prevention, but in a Japanese population where the EPA and DHS or DHA levels are already very high because they have a very fish-heavy diet. And so they ended up doubling the dose that they used in JELIS, which was about 2 grams, because they just kind of guessed, well, we don't eat a lot of fish, and so we need to have a higher dose to see if we can mimic that. So anyway, long story short, we've not seen a lot of benefit in omega-3s historically. I think where one of the major studies that we've seen back in, I think 2017 was the VITAL study. It showed that it reduced heart attack rates by about 28%, 30%. And they found that in people of African-American descent and those who did not eat a serving and a half of fish a week, they derived the most benefit. So almost a 20% reduction in death in cardiovascular disease and about a 40% reduction in heart attack rate. So this is a synthetically derived omega-3. The study was well done. There were a couple of issues with it, but it was a large, double-blinded, randomized control study that showed pretty obvious benefit. This was a study done in 2019 in a very specific cohort of patients. I don't think Dr. Crow hit on it, and I'm curious if you saw this yourself, but the benefit of about a 25% risk reduction that was seen despite the level of triglyceride that they got down to, right? So they got down to 498 or 170 or whatever, and they still saw benefit. And it wasn't dose dependent on how low they got the triglyceride level. So it kind of infers that the omega-3, that the benefit of cardiovascular death is not in the reduction in triglyceride level, it's something else. And this is something else that I don't think we have a good firm grasp on.
I think it's the inflammation, and I actually had a slide on that, and I don't know why it's not in this copy that I sent you, but the high sensitivity CRP was reduced by about 25%. So maybe it's a composite of lowering the lipids as well as the inflammation, and it's a composite effect.
Yeah,
but we don't know that for sure.
No, I agree with you, and I think so. I think whenever you get down to it, Visiva, I forget. I think that they said that there's about a $4 pill. I may be wrong about that.
Yeah, something like that.
But I think it's about $4. So it's a synthetic omega-3. If you want to get it through insurance, God bless you. You're going to have to explain how 15 other medicines didn't work. I think eventually that this will make it into the cardiovascular guidelines. I just don't think it's going to be there, and it's not going to be like a strong, massive 1A recommendation is my guess. But I think for patients, so take home, I think patients of African-American descent who've had a heart attack, who are on statin therapy, would benefit from being on moderate intensity omega-3 fatty acids. I think people who are under this cohort of patients who are not African-American, who eat less than 2 servings of fish a week, would benefit potentially from it. I think the side effects of this medicine that they saw in the study were increased bleeding risk and increased rates of atrial fibrillation, which are interesting because omega-3s are supposed to be antiarrhythmic. So I think that's weird, but I think you can offer that to patients in this cohort of people pretty easily with not a lot of downside effects.
Okay, I'm going to take over. This is Christina Connell. I'm just going to give some evidence-based medicine thoughts. So yeah, I agree. Overall, this was actually a pretty well done study. When we talk about placebo-controlled studies, most of the time, if we're talking about a placebo-controlled study, most people are going to be like, well, sure, you showed difference against placebo. Good job. Like, you're not doing anything. So while this was placebo, you also have to look at the fact that it was against the standard of care. And so it's not a true placebo in the fact that the control arm was doing nothing. They were on the standard of care. And so I think that is a plus, right? Like we know niacin doesn't really work. We know fenofibrate doesn't really work like we want it to. And so one of the things, and I think Dr. Crow did a great job bringing this out, is when you have a study like this that's comparing to the standard of care, was your control arm actually on the standard of care? And in this study, they actually did a pretty good job. I would say the 6% that were on a low intensity statin, they probably should have completely excluded that group, because it's hard to say, like, you weren't on guideline-based therapy. I did think it was interesting that about 70% of the cohort was secondary prevention, so they'd already had an event, but only 30% of patients were on a high intensity statin. So I don't know if that says more about our prescribing habits than it does anything else, or maybe tolerability of statins, etc. But I think it does show that at least 60% were on a moderate intensity statin, so most patients were on appropriate therapy. So when you talk about biases of an article, especially biases of an article that's placebo controlled, looking at those baseline demographics is going to be really important. What were the patients going in? What was your control arm? If it's a placebo, was the standard therapy being applied? Because I think we see all the time that articles get published and the standard of therapy arm is subpar. So in this article, I think they actually did a pretty decent job. So the other thing I was going to mention is the number needed to treat here is pretty decent, especially when you consider adverse effects and harms of giving omega-3 are really low. So you have a really decent number needing to treat for a population that, we have a lot of patients of cardiovascular risk, diabetes risk patients. So I think that's another thing that plays in its favor, is that it's a low risk drug, though rather on the expensive side, but with a decent number needed to treat. So that's another thing to look at is, do our benefits outweigh the risk? And I think here it's very clear that it does.